Hello, this is Dr. Debashish Danda on behalf of APLAR and APLAR Vasculitis Special Interest Group. I welcome all of you along with my colleague, Professor Harigai. Professor Masayushi Harigai is the one who organized the whole program. He has carefully chosen the faculty and the moderators and the facilitators for this excellent novel idea of case discussion to celebrate or to sort of conduct this session on the occasion of the International Vasculitis Day. So welcome all of you, and I'm sure from here onwards, I would like the program to be handed over to the facilitators. Thank you. Have a good time.
Hi, everyone. This is Professor Nikat Mir Ahmed. I am Chair of College of Physicians and Surgeons, Faculty for Rheumatology, Lahore, Pakistan, and also Chair of National Hospital Medical Center and Associate Dean of Rheumatic Diseases at Central Park Medical College, Lahore. It's my pleasure and honor to facilitate this webinar. I am extremely grateful to Professor Danda, who needs no introduction, and Professor Harigai, who both have put forward a great program based on this case-based discussion, which is challenges which are faced by rheumatologists, leave alone physicians and surgeons who come to see these patients either in the emergency room or in their clinics. My pleasure to introduce my co-moderators and facilitators, Dr. Monica Di Silvia, National Hospital of Sri Lanka, and Professor of Rheumatology, Dr. Tian. She's at Peking Medical College, Beijing, China. Welcome, and they will be working with us to facilitate this session. And so let me explain the flow of the session or of this webinar. We will have two cases. So the case one, after presentation, will proceed to discussion of the case by our esteemed faculty with some question and answer session, and then case two. Both cases are very challenging, so stay tuned to this exciting webinar. Welcome again.
Thank you, Professor Ahmed, for kind words of introduction. May I now introduce two discussants of the case one, Professor Zenbayo Wu and Associate Professor Hajime Yoshifuji. Professor Zenbayo Wu is the head of the Department of Rheumatology and Immunology, Tangdo Hospital of Air Force Medical University in Xi'an, China. And Professor Wu is also the deputy leader of vasculitis group, rheumatology branch of Chinese Medical Doctors Association and Cross-Strait Exchange Health Society. Dr. Hajime Yoshifuji is an associate professor of Department of Rheumatology and Clinical Immunology of Graduate School of Medicine, Kyoto University. Professor Zenbayo Wu, Professor Hajime Yoshifuji was the Prime Secretariat Manager for 2017 Japanese guidelines, and he also had great contributions to genomic study and clinical trials in Takayasu arthritis. So we hope great discussion with these two professors. And may I invite now Professor Tian to introduce discussions of case two. Over to you, Tian.
Hi, hello everyone. I will in charge of the discussion of case two. So let me introduce the to discussions of case 2. There's a professor. Sorry, I cannot find the bio of these two discussants. Sorry. Can I introduce the two discussions when after the finish of the case presentation of case 2, because
That's
I cannot
perfect.
find. Sorry, I will find
That's
out
perfect.
where I put.
Ian, that's
I put
perfect.
Okay, thank you. Sorry for this.
We can now proceed to presentation of case 1, a very challenging case, which will be presented by Professor Nyota Temuri from Juntendo University. And following that, we'll discuss the case. So let's look at this video and listen carefully, because all the discussion will be focused around the presentation of the case. So we can start with the video.
Hi, my name is Yuko Asanuma, and I'm going to present case number 1, Vision for the Future, How to Treat a Case of Takayasu Arteritis. A 17-year-old woman visited our hospital due to right vision impairment and unmeasurable blood pressure on her left arm. Present history. This case involved a woman with no notable past history who was incidentally found to have anisocoria at a high school annual health checkup. She visited a local ophthalmologist who noted a dilated right pupil, loss of right direct light reflex, right vision impairment, and bilateral papillary edema. She was referred to a neurosurgeon. Neurological examination was unremarkable, and an MRI revealed normal optic nerves and no masses. She was referred to the Department of Ophthalmology at our hospital. Neovascular formation on the iris without anterior chamber inflammation, retinal venous congestion and beading, hemorrhage, cotton wool spots were noted. The visual field test revealed visual field defect in her right eye. Fluorescent angiography showed leakage of contrast media from the blood vessels of her right eye, and the leakage was also observed in her left eye. These findings demonstrated her vision impairment was caused by retinal vasculitis, and the ophthalmologist found that her blood pressure was unmeasurable on her left arm. The Department of Rheumatology was consulted. The patient denied systemic symptoms such as fever, weight loss, and night sweats. She reported no arm or leg claudication. She had no significant past medical or surgical history. She took no medications and had no drug allergies. Regarding her social history, she has never smoked, drank alcohol, or used illicit drugs. She reported no family history of autoimmune diseases. On physical examination, her temperature was 36.5 degrees, and her blood pressure was unmeasurable on the left arm, 71/55 on the right arm, and 104/64 on the right leg. Her cardiac exam was unremarkable, but bruits were heard over the bilateral subclavian and carotid arteries. Brachial and radial artery pulses were difficult to palpate bilaterally. Abdomen was soft, flat, and non-tender to palpation, and there were no bruits over the renal arteries. The patient had no purpura, rash, or edema. Neurological examination was unremarkable. Lab data showed that the patient was slightly anemic. Inflammatory markers were elevated. The erythrocyte sedimentation rate was 85 millimeters per hour, and the C-reactive protein was 1.0 milligram per deciliter. Immunoglobulin G was elevated to 2,566 milligram per deciliter. CT angiography demonstrated significant stenosis of the brachiocephalic artery and bilateral common carotid and subclavian arteries with thickened arterial walls. MR angiography revealed there was significant stenosis 3 centimeters proximal to the origin of the right common carotid artery, as well as narrowing 2 centimeters proximal to the origin of the left common carotid artery. In addition, there was stenosis straddling the left vertebral artery, beginning 2 centimeters proximal to the origin of the left subclavian artery. In summary, a 17-year-old woman without significant past medical history was incidentally discovered to have anisocoria. She was subsequently diagnosed with Takayasu arteritis based on retinal vasculitis as well as thickened walls and stenosis of the first branches of the thoracic aorta on CT angiography. Here are 3 questions for the experts. 1. Would you give pulse methylprednisolone? 2. What would be your initial dose of glucocorticoids? 3. When would you start concomitant immunosuppressants and biologics, and what would you choose?
Thank you, Dr. Yuko Asanuma, for the excellent presentation. I'm sorry that the sound was a little low. Let me recollect the case. So here is a young woman who was found to have anisocoria as an incidental finding, and ophthalmologist referred the patient to the rheumatologist, and rheumatologist noticed as there was absent blood pressure recording in left arm. She was referred to rheumatologist, and in rheumatology, they noticed the difficult to palpate brachial and radial pulses, as well as bruise over the carotids and subclavian arteries. And imaging confirmed the diagnosis of Takayasu arteritis, and her ESR was 85. There was mild anemia with hemoglobin of 10, and CRP was 1, and immunoglobulin G levels also were elevated. And in addition, her fluorescent angiography of retina showed evidence of retinal vasculitis in both eyes with poor vision in right eye. So before going to the discussion, there are 3 questions from the presenter. So we know Takayasu arteritis, we treat with steroids. And first question is regarding indication for pulse methylprednisolone. So there are little discrepancies in about steroid treatment according to the guidelines. And according to 2021 ACR guidelines, recommendation is for oral steroids unless there is life or organ threatening disease. And 2017, the Japanese guidelines also, they recommend methylprednisolone pulses in case of emergency or in relapse. So I like to direct first question to Associate Professor Hajime Yoshifiji. Would you give pulse methylprednisolone in this patient?
Thank you, Monica. So can you hear me?
Yes.
Right? So this is Hajime Yoshifuji in Kyoto University. Thank you very much for inviting me and introducing me. So I will answer the first and the second question, okay? Then Professor Wu will answer to the third one, okay? So as Monica introduced, so there are some guidelines in Japan or EULA and LCR, right? So this is very simplified as schema of the guidelines. So every guideline will recommend for initial treatment, as initial treatment glucocorticoids, right? So usually medium dose to high dose. Then if the relapse happens, all the guidelines recommends biologics, and there are difference. So Japanese guidelines does not recommend the initial immunosuppressive drug use. On the other hand, so ACR and EULA guidelines are recommended initial treatment immunosuppressant. And so this the question was so whether I will use the prednisone pulse therapy, but I don't think so. We need a prednisone pulse therapy, so because it is not emergent case. So although this case is very severe with very hard occlusion of carotid arteries, but I don't feel so any emergency. So and no guidelines recommend steroid pulse therapy. Okay.
Thank you, Hajime, for this explanation. And second question regarding initial dose of steroids. And according to ACR 2021 guidelines, they recommend high doses of steroids, almost 1 milligram per kg, and with maximum dose of 80 milligram. And Japanese guidelines, 2017 Japanese guidelines is 0.5 to 1 milligram per kg dose. Yes. And EULA 2018 EULA guidelines, they also recommend high dose, but their dose is 40 to 60 milligram per day, not according to the body weight. And what would you recommend the initial dose of steroids?
Yes, thank you, Monica. So I will use a high dose. I will recommend high dose glucocorticoid therapy, and I saw this case, and so the CRP and ESR was not very high. So disease activities may not be so strong at this moment in this case. However, I think this case is very serious. She has very multiple occlusion of her carotid arteries. So she's at high risk of cerebral infarction. So she's very young, 70 years old. So, however, so she is at very high risk of sight loss, or very high risk of cerebral infarction, especially during pregnancy or during delivery of baby, right? So I may not allow her to be pregnant because it is very high risk or dangerous during that baby delivery. So stroke may happen. So hypertension is very dangerous. So I recommend at this time intensive treatment. So I will choose high dose glucocorticoids with some oral immunosuppressants. And one thing, so I don't recommend the stenting for recanalization because the stents will easily closed, easily occluded. So it is very dangerous. So I just use medication. Then I don't want to give up the pregnancy for her. So I will do the first strong therapy, and I will hope that collateral circulation will develop for her. At that time, we can consider about the pregnancy. That's why. So thank you.
Okay. So is it like 1 milligram per kg dose you recommend for this patient?
Yes, 1 milligram per kilogram. I will choose that. Mm-hmm.
Okay.
In this case, can I ask a question?
Mm-hmm.
So in this case, because of the involvement of the eye and active disease, would you follow the ACR or EULAR guidelines rather than the Japanese guidelines in such a case?
I'm sorry, I'm not sure about eye lesion. I'm not sure there are some comments or recommendation in some papers about Takaya's eye lesions. It is rare, right? So probably 100 years ago, so the prognosis is very bad. So there are many patients with sight loss. But nowadays, we don't have such case. So this is a very severe case. So she's still at risk of sight loss now. I think so.
Okay.
Thank you.
Thank you, Hajime, for the explanation, great explanation. Third question is regarding concomitant immunosuppressant. So according to the guidelines 2021, ACR guideline recommendation is to start non-glucocorticoid immunosuppressants from the beginning with steroids. So it's either biologic or non-biologic. So conventional disease-modifying drugs, they mention about azathioprine or methotrexate, and TNF inhibitors too. So to start from the beginning with steroids, either methotrexate, azathioprine, or TNF inhibitors. And EULA guidelines 2018, that's also recommend to start non-steroid non-steroid immunosuppressants, but conventional disease-modifying drugs, methotrexate, azathioprine, or leflunomide, mycophenolate mofetil, one of these. And only in flare-up or resistance, they recommend either TNF inhibitors or tocilizumab. According to Japanese guidelines, the recommendation is mainly for monotherapy to start with steroids, and in case of difficulty to reduce steroids or difficulty to induce remission, to start non-glucocorticoid immunosuppressant. So this, so I would like to direct the question to Professor Wu. So would you start other immunosuppressants from the beginning, or what is the choice? Yeah, when would you start concomitant immunosuppressant and biologics, and what would you like to use? Professor Wu.
Oh, thank you, Monica. Yes, in my practice, and at the beginning treatment of the Takayuki arthritis, with almost all the patients, we should use concomitant use the immunosuppressants. Because in our experience and the study in our cohort, and according to the recent 3 international recommendations, all the Takayuki patients treated with GC and immunosuppressants, the patients will more rapidly to suppress the disease activity and help us to reach the training the training goals, and especially only concomitant with immunosuppressants, the patients can reduce the doses of the GC, and finally some patients can stop the GC. I think this is very important in the treatment of Takayuki arthritis, especially we stop the GC and we still use the immunosuppressants, and the disease have less prevalence of relapse. So we should emphasize the use of immunosuppressants in the treatment at the beginning, at the initial treatment, and the following up and treatment. This is my opinion. As for biologics, usually when the standard treatment of GC and immunosuppressants, some patients can't reach the treatment goal, and some patients with very serious disease, that's as the high blood pressure, heart disease, and brain disease, brain vessel disease, and some very serious dangerous their lives. We should use the biologics. As for the 2 biologics, a recommendation in the international TNF blockers and interleukin 6 blockers, we usually use more interleukin 6 blockers, because in China, we have more prevalence of hepatitis B and tuberculosis. As we know, TNF blockers may have some bad influence in hepatitis B and tuberculosis. and interleukin-6 inhibitors have more safer profiles than TFR blockers. And in our cohort, we have study series. We found that have the two kinds of biologics have the same treaty effect, but interleukin-6 blockers may be more safer than TFR-alpha blockers. And sometimes, as for many patients have social economic problems, we use JAK inhibitions to treat some Takayasu arthritis. In our cohort, we treat more than 30 patients. We have a very good effects and safety profile. Maybe later we will publish these results. Thank you for.
Okay, thank you, Professor Wu. So in the absence of the risk factors, would you recommend TNF inhibitors than interleukin-6 inhibitors? Like in the absence of no TB, no hepatitis B, C?
Yes,
so,
yes.
Okay, right. So let me ask another question. So why the mycophenolate mofetil is not mentioned in the ACR guidelines, and how about mycophenolate mofetil or MMF in the treatment of Takayasu? Is it better than methotrexate? So what is your opinion, either Hajime or Professor Wu?
I have no experience to use mycophenolates on Takayasu arthritis. In my practice, so I use methotrexate, and if it failed, so we will switch to tocilizumab. I use tocilizumab just it is approved for insurance. So probably Indian doctors use mycophenolate mofetil or other countries. So just that's from my experience. Okay.
Okay. Professor Wu, what is your experience with mycophenolate mofetil?
Yes, we always use mathematics, isoprene, leftamide, and my wife. I found the same treatment effect, efficacy, almost the same. But we use the most often as mathematics.
Okay. So is there preferred conventional disease modified drug, methotrexate, azathioprine, MMF? So what is the best drug would you prescribe? What is the is there any preferred one among these? Methotrexate, azathioprine, MMF? Is it methotrexate? Yeah, with your experience?
Yes.
What is the best one out of the conventional disease modified?
Sometimes we use leftamide in our country.
Okay, thank you, Professor. So there is one question appearing in the chat box about parameters for disease activity and which imaging modalities best in picking up active disease before devastating clinical care. So asking about the parameters of monitoring the disease and the best imaging modality to pick up the active disease. So,
okay, so yeah. Let me start. So just we are in the daily clinics. I just use CRP and ESR. I mean, inflammatory markers in blood samples. Okay, then so in Japan, so we can use PET scan, PET CT. So like this case, very severe case, and if we have to decide the strength of the drugs or something, so also we may order a PET CT to see if the aorta are still have inflammation. But I have no other so good modality. I think so. Okay.
Okay. May I ask another question? So, in the absence of MRA or aortogram findings in imaging, just presence of active disease in PET scan. So, is it possible to diagnose in a patient with presenting with aortic regurgitation? Is it possible to diagnose as Takyasu arthritis if there is activity in PET scan?
Excuse me. So
explanation. Yeah.
So just a simple CT is also okay, right? So we can use a contrast enhanced CT in the inflammation of aorta, inflammation of cervical arteries, or like that.
Yeah.
So I think it's standard for the initial diagnosis. However, some hospital does not have CT probably, so it's hard to diagnose. I think so.
Okay.
Would you prefer MRA over PET scan? Would you prefer MRA or PET scan for assessing disease activity? Can you hear me?
Me? So I use MRI also. You know,
Okay.
most of hospitals have a CT machine, so usually we use CT. I'm very fond of CT, but you know, MRI is less invasive. You know, these are very young and female, so in case I will do the MRI to see that, you know, stenosis or some elongation of aorta like that. So MRI is also good. I think so.
Okay, thank you.
I have a question for Dr. Wu. Which TNF do you prefer? Which TNF inhibitor?
TNF inhibitor usually we use Inflamax. Maybe Inflamax. Yes, I prefer. Yeah.
Okay, thank you.
Okay, thank you, Professor Hajime Yoshifuji and Zenbayo Wu, the great discussion.
Thank you very much. Nice to talk
Thanks
with
a
you.
lot. Thank you so much. We can now go on to case 2. It's a
I've been tossing and turning in my.
I'm Hiromi Chitamaki. I'm going to present case number 2, gasping for hope, a case of pulmonary renal syndrome. This is a 58-year-old man with no known past medical history who has noticed bilateral leg edema for 1 month. He also had orthopnea. He developed cough and bloody sputum 2 to 3 days prior to admission, and he planned to go to hospital on the next day, but he was too short of breath. Then he called ambulance. On the arrival of ambulance, saturation was 60% on room air, and he was transferred to our hospital with 8 liters of oxygen. He has no known past medical history or surgical histories. Actually, he hasn't sought for medical attention for many years. He doesn't take any medications. He has no known drug allergies. Social history, he smokes half a pack to a pack a day for 30 years. He denied alcohol or illicit drug use. He has no family history of autoimmune diseases. Physical examination. His temperature was 37.9 degrees Celsius. Pulse rate was 105. Blood pressure was 168/92. Saturation was 94% on 8 liters of oxygen. He was in acute respiratory distress. His conjunctiva was anemic. He has bilateral crackles all over the lungs, but cardiac edema was unremarkable. Abdomen was soft and flat and non-tender to palpation. He didn't have any purpura or other rash. He has significant bilateral leg edema, and he didn't have any signs of synovitis. Neurological examination was unremarkable. Laboratory data. He has mild leukocytosis at 8,900. He was anemic. Hemoglobin was 10.0. Platelet count was normal, and PT and APTT were both normal. Creatinine was elevated at 4.37 with the estimated glomerular filtration rate of 12.2. Inflammatory markers are markedly elevated. C-reactive protein was 18.4, and set rate was more than 100 millimeter per hour. Urinalysis was also abnormal. Urine protein was 2+, and urine blood was 3+. Urine microscopy exam revealed more than 50 red blood cells per high power field, and RBC test was observed. Complement level was mildly low at 60, with the upper limit of normal being 65. Hepatitis panel was negative, and his procalcitonin level was elevated at 4.99. Chest X-ray on admission revealed severe bilateral lung infiltration. CAT scan was obtained, which showed, again, severe bilateral lung infiltrate as noted here. Of note, he has bilateral renal hypertrophy. Here's his hospital course. Day 1, he was intubated because of the respiratory failure. Bronchoscopy was obtained, and bronchoalveolar lavage was sent for cultures. Also, blood culture was obtained, and antibiotics was studied. Day 1, his creatinine was 4.39, but day 2, it rose up to 4.99. Rheumatology consultation was obtained day 2. On the first day, his urine output was only 390, and he was oligouric. Summary: a 59-year-old man without significant past medical history developed severe pulmonary renal syndrome and is currently on ventilator. Infectious workup is pending. So here are some questions to the experts. What is your diagnosis? What data do you order to confirm your diagnosis? How would you treat initially?
Hi everyone. We finished to listen to the. We finished to watch the video for case 2, part 1 presentation. So first of all, let me introduce the 2 participants, 2 discussants for this case. They are Professor Chan Bo Choi. He is the professor from Hanyang University Hospital for Rheumatic Disease, Korea. Our second discussant, Dr. Masasu Kashimoto. He is a doctor from Keiryon University School of Medicine, Japan. So we just finished listen to the case presentation. This is a 58-year-old male patient with very severe dyspnea, short of breath. So his chest X-ray and CT scan showed that there's a very severe bilateral infiltration, and the patient has very prominent urine problems. He has proteinuria and hematuria, and he also has the hypertrophy, the kidney in his CT scan. So this is a critical ill patient. Based on his lab test, he has a positive ANCA. So he might have the ANCA-associated vasculitis, and he has both the renal and pulmonary problems. So according to the classification criteria of this patient and based on his laboratory presentation and his image modalities, we think that the patient could be diagnosed as ANCA-associated vasculitis. So based on the history, we have several questions for our discussant. Can we show the slides for the questions for our discussant? So let me ask our two discussants about the following questions. What is the diagnosis of this patient? Actually, I actually try to answer this question. So may I ask Professor Choi about this first question? What is the diagnosis of this patient? What is the diagnosis of this patient?
This is a patient who were presented with their symptom of pulmonary disease and renal disease. So it's a pulmonary renal syndrome. And most of the pulmonary renal syndromes are caused by autoimmune diseases, including ANCA-associated vasculitis, but also other diseases such as lupus or choroideremia can cause these symptoms. But the history shows no other symptoms or signs that are suggestive of other autoimmune diseases. So our first guess would be ANCA-associated vasculitis and other vasculitises. And also the anti-GBM disease can cause same symptoms and cause same presentation. So that will have to be one of the other diagnoses that we have to rule out. But with the testing of the ANCA and the anti-GBM, I think we'll be able to diagnose this patient either as an ANCA-associated vasculitis or as an anti-GBM disease.
So is there any differential diagnosis of these patients besides what you suggested as the ANCA-associated vasculitis or anti-GBM disease?
So the other autoimmune can also cause these symptoms, but his symptoms and signs didn't show any evidence of other autoimmune disease. So we would have to order an ANA test or other ENA test. But from the history of the patient, I think the possibility of having other autoimmune disease can be very low.
So what data do you order to confirm your diagnosis?
We first have to order the ANCA and anti-GBM and ANA also to rule out other autoimmune diseases and ENAs if possible. We will also have to rule out infection. So the test to rule out infection should be performed. But from the history and his symptoms and signs, we didn't see much sign of the acute infection. So I think infection is a distant second possibility in this patient.
So thank you for your answer of these two questions. Let me ask the question for Dr. Kishimoto. How would you treat initially for this patient?
Oh, yeah. Thank you for asking me. So could I add the comment about the diagnosis and the differentials? Is okay?
Yes, please.
Yeah. So the patient didn't have any significant medical history, although he didn't seek any medical attention for any in the past. So we don't know the chronicity of this disease. And in this case, the second day after this evaluation, the rheumatology team on board, initially I'd be cautious to start high-dose pulse steroids at this moment. So I would like to confirm this is not the infections. Pulmonary renal syndrome can be due to infections like Leptospira infections or pneumococcals. Any bacteria can cause alveolar hemorrhage. So initially broad-spectrum antibiotics with the doxycycline to cover the other tick-borne disease. and then cautiously start the. I'd like to make sure there's no culture grown for 24 hours because this is second day of the hospitalizations. And then, as the doctor, I completely agree, Professor Choi. He has hypocomplementemia, so they want the differential with the lupus. And then also antiphospholipid antibody syndrome, like a CAPS, catastrophic APS, also can cause these pictures. So I would love to check the antiphospholipid antibody as well. And then send out all the serology for lupus or Sjogren's and ENA antibodies. For that, I would like to start the 1 mg per kg IV solumedrol, and then cautiously wait every day to check the culture result. And then if the patient responded to 1 mg per kg solumedrol, I don't use the pulse, but if they don't respond, I add the pulse. But already he has a creatinine of more than 4. So possible, as Dr. Choi said, he may have a GBM disease or the smoker and a male. So that's a GBM disease is possible. So that I may start the plasma exchange if the patient doesn't respond, and they, after confirming the blood culture and sputum cultures.
So may I ask one question about the diagnosis of this patient, especially the differential diagnosis? Because this patient has very severe lung infiltration in his both lungs, and the patient has very rapidly progressive dyspnea. So for the differential diagnosis, you think about infection should be the first diagnosis that should be differentiated. So based on your suggestion, do you want to perform the pulmonary lavage for this patient to make sure that the patient's,
Yeah, I love to do that because he already intubated. So anyway, so we can do the lavage anytime. So also in addition to that, I love to send out the cytology for the lymphoma thing as well.
Okay, because these patients had very severe bilateral lung infiltration, would you consider pulmonary hemorrhage in this patient?
Yes, and then we can confirm by lavage as well.
Okay. Do you consider the patient might have some kinds of heart problems caused by heart problems caused the bilateral infiltration? Do you want to put the heart failure as the differentiation?
Yeah, we often care the patient who had a mild pneumonia, exacerbated CHF, and then post AKI at the same time. So and then he also had a sky high NT-proBNP, and then although we don't know the chronicity of this patient, is poor historian maybe, so already intubated. So it's difficult to obtain the prior short breath history. So I would order the echocardiogram to make sure any endocarditis or low ejection fractions. I'd love to see that too. Thank you.
So thank you very much for.
Can I ask a question?
Okay, sure, please.
Yeah, in such an acute emergency, when you're suspecting infection, and we know that infection is the biggest cause mortality of these patients, would you wait for the cultures to come back, or would you just, on the basis of clinical, thinking that this is ANCA associated, would you just start?
That's why I said 1 mg per kg solumedrol at the same time of the broad spectrum antibiotics, not the pulse on the first day. Probably third or fourth day, I would love to do the pulse if it doesn't have any positive cultures.
Thank you.
Thank you very much for your answers. Because time is up, so we will move to the second part of the history of the case.
Professor Dr. Demaki will present the second part of the case, a very interesting and a challenging case, and how do we manage it. So the gasping for hope, hopefully we'll find an answer to this and really lead to an interesting discussion amongst all of us. So let's listen to what happened next.
This is the latter part of case 2. On day 2, rheumatology consultation was obtained. Due to a concern for infectious etiology, pulse methylprednisolone was avoided. Instead, methylprednisolone 60 milligrams was initiated. On day 3, his creatinine further rose up to 5.65. Dialysis was initiated due to anuria. After confirming the culture remained negative, pulse methylprednisolone was initiated. Plasma exchange was also started for possible anti-GBM disease. Following 2 days, the same therapy was continued and the patient's status improved. On day 6, serology results came back. Anti-MPO ANCA was highly positive and anti-GBM antibody was negative. Plasma exchange was discontinued on day 7, and the patient was extubated on the day 7 as well. On day 8, rituximab was given for ANCA-associated vasculitis. So here are additional questions to the experts. Number 1, would you start plasma exchange in this case? If so, when would you start it? Number 3, would you continue or stop plasma exchange when anti-GBM antibody turned out to be negative? Thank you very much.
Thank you so much. The case has now unraveled itself and is very interesting. We'd like to open the discussion. Thank you so much, Dr. Tamaki, for this presentation. I would ask Dr. Kishimoto the questions which pertaining to that we started the plasma exchange. So we all know that since 1980, plasma exchange has been used for pulmonary hemorrhage and for renal syndromes as well. We had very small trials, and it was just based on the information that it's capillaritis in the lungs as it is in the kidney. But now we have data and very interesting studies, which I'm sure you're going to touch upon, that what are the factors which guide us whether we are going to use plasma exchange or not. So I would request you to discuss this very important question.
Yeah, thank you, Nikki. We have welcomed also Hiromichi Tamaki as well. He completed a fellowship, the Cleveland Clinic, and a vasculitis fellow. So he gave us our comment as well. So the first question, would you start plasma exchange? I said after confirming blood culture for a couple of days after the consultation, I would love to start if that creatine doesn't come down. Because our hospital, the GBM antibody would take about a couple more 2 to 3 days. So I'd love to start beforehand. And in addition, for the ANCA vasculitis, let's look at the guideline, ACR recent updated guideline. As you know, the active severe GPA, MPA, rituximab, cyclophosphamide, but rituximab over cyclophosphamide, but doesn't say plasma exchange in the severe patients. In the here, recommendation in items, you can see here, GPA with active glomerulonephritis, we conditionally recommend against. So that's against to routine addition of plasma exchange the patient. How about here, the patient with active severe GPA alveolar hemorrhage, like our case, we conditionally recommend again. This is against adding plasma exchange. Why is that? And that's based on the great system that the systematic literature review. And the first one, as you know, the PEXVAS study, severe ANCA vasculitis with standard therapy. They added the plasma exchange, and then also those group also subdivided into the low dose steroids and high dose steroids. Then here, Plex doesn't add any difference to the death or end-stage kidney disease. So the Plex group has higher rate of infection, of course. Let's look at the other study. Professor David Jane did this study. And then this study looking at the ANCA vasculitis patient with a severe renal failure, creatinine more than 5.8. And then this compared the IV high-dose methylprednisolone, solmedrol, versus plasma exchange in addition to the standard therapy. With ANCA vasculitis with severe renal damage, creatinine more than 5.8. In that study showed the achievement of renal recovery is higher, better in the plasma exchange group. So they concluded, although mortality and adverse reaction rate is not different, but they concluded the plasma exchange may use these kind of severe sick renal ANCA vasculitis patients. Let's look back to the New England Journal study. This is the confidence interval of the primary outcome, the subgroup analysis. As you can see, age older than 60 just crossed the 1, and also creatinine more than 5.6 here. Just crossed the 1. So maybe we can say the elder high creatinine patient had better outcome. We shouldn't say better, but we may have options for that. I would stop here. Nikki?
Yeah, that's great. Can I ask quickly a question?
Yeah.
Because if we did not have the subgroup analysis, I don't think we would be using plasma exchange. This was a very good publication. And now we go on to discuss this further with Dr. Hiromichi Tamaki, who got all his experience from vasculitis clinic and Cleveland Clinic. And it's my pleasure to ask him what does he think about this plasma exchange, when do we introduce, what are the risks involved in it. And I think there was a very nice article which was published lately in April 22 Practice, which is a very good reference for these questions which spring in our mind when we see such cases. So I'm going to welcome Tamaki.
Thank you for a nice introduction. So I'm Hiro Tamaki from St. Luke's International Hospital. Let me share my thoughts. And in this case, basically, his creatinine level was around 5. So as Dr. Kishimoto introduced, it doesn't meet the criteria for MIPIC trial, second trial that Dr. Kishimoto showed. So with regards to this patient, actually, maybe if this were only ANCA-associated vasculitis, he doesn't really meet the criteria for Plex. However, still while waiting for the anti-GBM antibody results, presumed diagnosis with anti-GBM antibody disease, we can do some Plex. However, recently, there was an ANCA meeting in Dublin, 2022, and there was some new data emerging as well. So let me introduce those results as well. So next slide, please. So this is basically a meta-analysis that was done in addition after adding PEXVAS trial. And in terms of the benefit of plasma exchange, as you can see on the left side, it doesn't really change 1 year mortality. However, at the short term end-stage renal disease at 1 year, there seems to be some benefit of plasma exchange, and risk ratio was 0.62. Next slide, please. Interestingly, actually, there's some risk found with plasma exchange as well. Infection rate seems to increase by 27%. Next slide, please. So this is actually Michael Walsh's presentation at the ANCAP meeting back in Dublin in early April. So basically, based on risk of end-stage renal disease, from the top to the fourth row, it is low risk patient with the risk of risk of 0.2%, and then low to medium risk of 5%, medium to high risk of 11%, and very high risk of 38%. With PREX, we can reduce those risks down to 0.1, 3.1, 6.8, and 23.5%. That means, for every 100 patient PLEX, you prevent 0 cases for the low risk patient, 2 cases on the low to medium risk patient, and 4 patient from a medium to high risk patient, and very, very high risk patient, you prevent 14 cases of end renal stage disease. And in terms of infection, again, same thing, from low to high, 10, 18, 31.5, and 50%. The risk increased by 27%. So that means 12.7%, 22.9%, 40%, and 63% from 5th row to 8th row. So by doing PLEX for 500 patients, you increase the infection by 3, 5, 9, and 14 respectively. And based on these results, actually, BMJ, British Medical Journal, published a rapid guideline in terms of the plasma exchange. Oh, will it show up actually?
Right here.
Yeah, this is the one. So, low risk, low to moderate risk, moderate to high risk, and high risk, it is basically classified by creatinine level, 2.26, 2.26 to 3.9, 3.9, 3.36 to 5.65, and above 5.65. They recommend plasma exchange above moderate to high and high risk patients. And then low risk and low to moderate risk patients, they do not recommend plasma exchange. And in terms of pulmonary arterial hemorrhage, actually, there's not sufficient data. So far, they recommend standard care. That's the current status of the plasma exchange. Thank you so much.
Can I have a question?
Sure.
So basically what they're saying is that if you have a high risk of end-stage kidney disease, which is by the level of the creatinine, it will benefit those patients. And let's not give plasma exchange for patients who are at low risk because of infections. So we have to choose our patients carefully, because especially in our countries, with central lines and with blood products being administered and peripheral lines, I think this was universally seen that infections is also a very high cause of mortality and morbidity in such patients. So this is one, I think, take-home message from the management of this complicated case, which was very difficult. So we can, thank you so much. That was excellent data. And there's another, question which we can go ahead and ask Dr. from Joy, that with rituximab, where to go? Should we use in such patients, and what will be the indications for using rituximab?
So the rituximab is currently recommended as the first line compared to cyclophosphamide because the evidence show that rituximab is at least as effective as cyclophosphamide, and the adverse event from using rituximab is significantly lower from the cyclophosphamide. So I think in all patients with ankle-associated vasculitis, the first recommendation as per ACR guideline would be the rituximab currently.
So that would probably be rituximab. Any other questions from our panelists?
Could I add a comment about the rituximab? Because
Yeah.
patient have a severe renal damage, it's difficult to give enough dose of cyclophosphamide in this regards.
Yeah.
So I think I completely agree with Professor Choi.
Yeah. Another thing which I wanted to share with you is that when they are presenting only with pulmonary infiltrates, the recommendation is that you will not treat them with plasma exchange unless they are hypoxic due to the huge alveolar hemorrhage. Is that right? So you will only treat them with plasma exchange if the patient is hypoxic. Again, I think because of the risk of the infections and high mortality which is associated with it, right?
I think there's a slight difference of perspectives between rheumatologists and nephrologists regarding plasma exchange. So the generally nephrologists favor plasma exchange because they are experienced anti-GBM disease and they are very comfortable with renal replacement therapies. But the evidence currently show that even in those patients with high creatinine, the effect of the plasma exchange is not demonstrated in the long run, in the short run. So in my perspective, the plasma exchange in patients, even with those with high creatinine, should be avoided.
Okay, yeah. Okay, thank you so much, Professor Choi. Tian, Monica, do you have any questions to ask here?
No, thank you.
Okay, Monica?
Thank you. Yeah, thank you, sir.
So when do you, so once the patient is in remission and you are considering rituximab maintenance, so it would be the same as every 6 months, right? For how long, we don't know. Is that right? Once you have, induction is complete and patient is responding. So obviously for the best maintenance therapy for such a patient would be rituximab. Dr. Choi or?
Yes, the maintenance therapy also is very effective with rituximab, and the evidence show that maintenance rituximab is favorable. But it's not clear how long we should maintain the maintenance with rituximab. And the other issue is always the insurance reimbursement. They are very reluctant maintaining long term, so we have to fight that also.
Yes, that's true. Yeah, go ahead. Monica?
So is it the 500 milligram weekly 4 doses? Is this the dose that used for induction? 500 milligram weekly 4 doses of rituximab?
Yes, the evidence shows that this 375 milligrams per square meter or the usual dose that we use for the RA, 1000 milligrams twice a week after 2 weeks, are equally effective. But currently in Korea, only the 375 milligrams per square meter is reimbursed by the agency.
Okay. So another problem nowadays with COVID-19 is that patients come in this acute, situation, and they are not vaccinated for COVID-19. And of course, you cannot wait, before you start treatment. So what would be the right time to do the COVID vaccination after you've already given them rituximab? Dr. Choi, Dr. Kishimoto, Dr. Kimaka, any
Hiro?
showing when we could safely and effectively do the vaccination after rituximab. But from the other studies from oncology and from the RA, it's safe to say that we should at least wait 3 months after the infusion of rituximab to have the effective vaccination.
Okay, that's great. That's great.
Can I say something?
Yeah, sure.
In terms of rituximab vaccination, basically, rituximab blunts the vaccination effect, so patient cannot mount antibody response. Data basically says if CD19 B cells comes back to blood, they can mount some amount of antibody against the COVID-19. Also, if patient has already gotten 2 doses and a 3rd dose, apparently seems to be more efficacious with regards to mounting antibody response. So as further away from the rituximab dose, patient have more efficacy of the vaccine is what the data shows. But it is very difficult to balance between disease activity and vaccine issues. So that's very tough things to do.
Yeah, it is very hard when you are a clinician and the patient is sick, and we are all scared of COVID-19 and its complications, and we don't know that our patient is not vaccinated. It's a big challenge to
Yeah, in addition to the humoral response, I think cellular response can be achieved by rituximab, the booster or primary series. Especially booster can boost the cellular immunity. So I love to give a booster for the even on the rituximab treatment.
Okay, so how do you time it?
The ACR recommended 1 month. ACR recommended 2 to 3 weeks prior to the every 6-month doses. However, it's difficult, but they recommended that. Yeah, right. So wait a couple weeks before giving the rituximab then. Yes,
that's true. Very interesting discussion, a challenging case, and vasculitis is always very challenging. I know we did not discuss the mimics of vasculitis, which we would in another webinar, and I think they are as important, most importantly, the infections, which can mimic these diseases, and we as rheumatologists are aware of such situations. And I personally think that in our countries where there are not so many rheumatologists, it is very important that we have these webinars for family physicians, for medical consultants, and actually every field, as we know that they can present anywhere in any clinic, just like the Takayashi's presented in the eye clinic. And this gentleman, most of our patients land into nephrology units. So they should know that our diseases present like this. Any more comments by anyone? And what are we doing with the time situation here? Okay, so. Yes, Monica, you had something to say?
Time is up, I think, Professor Ahmed. Time is up, and then we have to hand over to Professor Harigai.
Yes.
Okay.
Professor Harigai, you were the man behind the show. And thank you so much for organizing this. And, for Professor Danda, who's done so much work on vasculitis and is a guru in this region. And, but you worked with all of us and, guided us, and that was fantastic.
Yeah, let me give a short message. This is Masayoshi Harigai from Tokyo Women's Medical University in Tokyo, Japan. As a co-convener of Vasculitis SIG and organizer of this webinar, I'd like to thank all the participants and audience of this wonderful endeavor. Different from conventional symposium, it took a lot of time and effort to prepare for it. but I believe that this webinar was really educational and helped young rheumatologists to understand the current management of vasculitis by the experts. I hope all you enjoyed it. Thank you.
Thank you so much.
Thank
We
you.
should thank Monica. Will you conclude by thanking all our discussants and presenters? And
So at the end of this very interesting and educational webinar, interactive webinar, I would like to thank Professor Debashis Danda and Professor Masayoshi Harigai for conveners of APLA's Vasculitis Special Interest Group for organizing this webinar. And I must thank the expert panel for the great discussions and information they shared with us. Professor Hajime Yoshifuji from Japan, and Professor Zenbayo Wu from China, and Professor Mitsumasa Kishimoto from Japan, and Professor Hiromichi Tamaki from Japan, and also Professor Chenbam Choi from Korea. I thank all of these experts for sharing their expertise with us. And I would like to thank the presenters, Dr. Yuko Asanoa and Dr. Tamura for bringing their great cases. And lastly, I thank Professor Ahmed and Professor Naigat Ahmed and Professor Sinfing Tian for moderating the session. And lastly, I would like to thank all the participants for being with us in this evening. So have a good evening, and thank you all for your great participation. Thank you.
don't forget the EPLAR 22, which is going to be, and save that date, 6 to 9 December 2022 in person. And we can throw that slide in for everyone who's watching so that they can join us in Hong Kong this December. It's not, it's going to be physical. So that would be great after 2 years of COVID. And I'm sure EPLAR will be looking forward to seeing you all there. Thank you.